Good morning, everybody. Dr. Gabriel Jasper with Jeremy Vickers.
Yeah.
All right, this is our podcast. By the way, what's the name of this podcast?
This podcast is called Painless with Dr. Gabriele Jasper, MD.
Maybe some people might not think it's painless if they listen to me, but some people like it.
Oh, believe me. I mean, I have had an endoscopic discectomy without anesthesia, and I can contest that you do things painless. Yeah.
It's a little uncomfortable getting a 8mm tube into your back, into the spine to take out herniated discs, bone spurs. Probably not real comfortable, but that's okay.
And
you did good.
I always say it's not even close to the worst thing I've ever done.
All right, so let me introduce myself. I'm Dr. Gabriel Philip Jasper.
That's right.
I'm an interventional pain physician, MD, board certified in anesthesia.
Mm-hmm.
I've done surgical residency and anesthesia residency, and I've been fully trained in the subspecialty of interventional pain, and I'm still being trained. It's an evolving field.
Never ending.
It's still in its genesis.
Yeah.
Not like other fields of medicine that pretty much, it's mastered and they got it down pat. But there's always, no matter what it is, you're always learning new stuff and new things are coming out. Thank God for the people who are out there, the doctors and scientists that are out there figuring these things out, who don't have actual hands-on experience with patients, but they're out there and this is what they like to do to make our job easier and safer.
And like creating
more efficient.
New innovations in technology to be able to do things you could never do before.
That's it.
Yeah.
That's what's going on. And it's always been going on. But anyway, what I do is I do interventional pain, and I always like to give a little bit of my own definition of interventional pain. Not everybody might agree with me, but it's a type of subspecialty where we do things to get rid of pain. We don't treat it with pain medication. For example, we treat it with getting rid of the pain source. So our expertise is actually finding what the pain generator is. And what makes it difficult and interesting for us is the fact that there are many, many times multiple pain generators causing the same pain. So we talk about the process of elimination, which it's hard to say that in medicine, a process of elimination.
Right.
But that's what it is a lot of time. It's being a detective, especially in interventional pain. You got to be a detective. You got to figure it out. And the ones that can figure it out are the ones that are successful.
Yeah.
And the ones that are successful who figure it out, usually they step out and they go the extra mile to figure things out. For example, starting with education. You need to learn while you're in the position of learning. And I think I talked about this when I did my residency in anesthesia and in pain. There were a lot of guys there and women, physicians that were training that would take shortcuts to get out of work. Oh, let's go down the park. We don't have to go. We'll go down the park.
Right.
This is our time to learn. Yeah. Let's learn what there is out there to learn today, because later on there'll be other things to learn.
Doc, that's passion, right?
Well, it's a matter of integrity and wanting to be the best at what you do.
Yeah.
And if you don't learn it, then you're not going to be the best.
Right.
Some people learn it and it's still not the best, but you need the background, you need the base of learning how to do things. And I was always there in the forefront as far as volunteering to learn how to do things. Did the extra stuff, because the more practice you get, the better you get.
Yeah.
So that's a little philosophy on my part. But what we do is some of the procedures that we do, basic procedures, epidurals. That's the most common procedure that we do, and that decreases the inflammation of the nerve that's causing you to have back pain or sciatica type pain. We also treat arthritis, and we treat that by not actually pulling the joints out of the spine and replacing them, because you can't do that. That's physically impossible because there's so many joints and it's so intricate down there. As soon as you start operating that area, it's starting to cause scar tissue,
Right.
and you can injure the nerve that way, or injure any kind of neurological structures. Even if you do everything perfectly, in the realm of medicine, standard of care, things could happen. So a patient said, yesterday I had a patient that came in and said, "Doc, I feel like 80, 90% better, but can we do something else?" And I said, "Well, you don't really need it because of the fact that you might even get better from here on out. So why take a chance? If I
Right.
stick a needle in you, there's always a chance of something bad happening compared to not sticking a needle in
Right.
you." Is it worth the risk of that 5%, 10%? Probably not. Depends how, plus that's subjective, the pain, what people feel with pain. Now, so the way we treat arthritis is we do what they call ablation or radiofrequency lesioning of a specific nerve that comes out of that joint that brings pain sensation to the brain.
Yeah.
We stop that nerve from working, you don't feel the pain. Is it magic? Some people call it magic. You use a magic wand, which is a needle hooked up to a generator. You turn it on at 80 degrees Celsius for 90 seconds. The nerve stops working. You just cut the extension cord from the pain going to the brain.
Right.
So you don't feel it. It's really came out over 20 years ago, and it's still paid for and done because it really helps patients.
Yeah,
These are the patients that get up in the morning. They have a ritual when they get up in the morning. This might be somebody listening.
Yeah.
They get up in the morning and they get out of bed. They walk to the bathroom. They got back pain. All the joints are hurting. And by the time, maybe some of these patients take some kind of NSAID like Advil, Motrin, Aleve, even Tylenol. And then, within an hour or so, an hour and a half, they move around. They start to feel better. And then the rest of the day is not bad.
Yeah.
Unless they overdo it.
My ritual was stretching in bed. I'd be like 20 minutes of like twisting and stretching out my, my body, and then I would get out of bed.
Well, this arthritis treatment, when you, let's say layman's term, burn the nerve,
right?
It's not actually burning the nerve. It's not like you're going in there singeing it. Well, you could do that if it gets bad enough, but you burn the nerve, you ablate the nerve, you radio frequency lesioning the nerve,
right?
And these people, virtually that ritual of getting up in the morning is gone.
Mm.
And
you're not kidding. You're not kidding. Yeah.
You had it done.
Yeah. It's like somebody flipped a switch off. I'm rolling out of bed without a grunt. And if you're suffering from arthritis in your spine, that grunt when you roll out of bed, And
it's been around for a long time. The only downside is that people tend to heal.
Mm.
Thank God. And some people heal faster than others.
Yeah.
So some people, that nerve could heal up fast, and some people it doesn't heal up at all. So depending on how fast you heal, depending on how long it takes for the pain to come back, and usually it never really comes back as much.
Mm.
But the average person, that pain comes back after a year.
Yeah.
But but talking about this subject about today I want to talk about, after I finish telling everybody what we do here, I want to talk a little bit about insurance.
Oh,
insurance, it's a downfall and it's the upfall. It's good and it's bad.
Yeah.
And we're going to talk about that.
Oh, good.
And I get anxiety when I talk about insurance because it's not my field of strength as far as my forte. I'm getting more knowledgeable on different types of insurances, what they cover, what they don't cover.
Yeah.
But
more hands-on on it. Yeah.
I'm not like the billers and the coders that could tell you a lot more about it. But it's constantly changing, evolving, and usually not for the better.
Mm.
But going back, and the reason that I just brought that up is because we used to do, when we first started doing this ablation of the nerves, and if there's anybody in there that are listening to us that knows about this, I wish we haven't activated the telephone yet, but I wish we could. So
we will get that by next week, I promise.
Yeah. And but anybody they could actually talk on how can they communicate here on our
right now you can text in real time on Facebook and YouTube. So we'll feed, like right now we got Your sister Maria Jasper, she says I need to make an appointment. Must be great having a brother who can take care of all that, right?
Yeah, there should be an opening. Maybe I think it's 6 months. No, actually, that's another subject. You got to wait in my office because if you call up and you're in severe pain, we'll get you in that day or the next day.
Right.
Put that out there. But as far as this radio frequency lesioning, ablation, burning the nerves, when it first came out, it was a game changer. And I'll tell you one of the reasons why, because in itself, it's a good procedure. But the physician would look at the MRI, look at x-rays, do a physical examination on the patient and determine which joints hurt the most.
Right.
You have some patients that the majority of them, the lower joints, because that's what takes the most load of the spine. And you do those and they do great. But you have a lot of patients that have severe degenerative disc disease all the way up the lumbar spine, even into the thoracic and the neck. And they came out with, we used to be able to burn every one of those nerves that was appropriate for that patient, that particular patient. And then they changed, which was great. Everybody did fantastic. Now, as they changed the rules, for example, they changed the rules. You're only allowed to burn the lower 3 nerves. Otherwise, they don't pay for anymore. So what do most doctors do? These needles, these device people, it costs money for the doctor.
Yeah.
So we're forced to do 3 nerves. Now, each joint, it's a little technical, but you need to understand this. Each joint are innervated. In other words, you need 2 nerves. You need to kill 2 nerves for each joint. Right? Otherwise, the one nerve is still going to bring pain sensation.
Yeah.
So if you're doing 3 nerves, you're only satisfying 2 joints. And most of these people have 5 or 6 joints that hurt. So how are you going to possibly feel that much better?
Right.
So it's kind of like, now it's getting discouraging because and this was before they changed it to make it worse.
Right.
That was okay. Well, because sometimes you do those 3 nerves, patients come back, I'm 60, 70% better and I'm okay.
Yeah.
Which is good. It's cost effective for the insurance company and the patients feel better. And we're all satisfied. But some people came back and said, doc, I really don't feel any better. So I would give them the old, let's take a classroom of 50 students in kindergarten. They're all screaming, all 50 of them.
Right.
And you keep 20 of them quiet, it's still going to be pretty loud in there. In other words, you're still going to hurt.
That's a great analogy.
And they understand that.
Yeah.
I said, but now we have the ability, after we burn those first 3 nerves, if you do have more pain and it's not enough to burn those 3 nerves, we do the rest, which was great. And you're allowed to do that once every 6 months because sometimes the nerve grew back every 6 months. The average is a year. Remember I said that.
Yeah.
But now they made it even worse. And it cannot last like this because it's a dilemma where we don't know what to do now because the new rule is you can only burn those 3 nerves and you can't burn the upper ones or burn those 3 nerves again for a year.
Oh, Jesus.
For a year.
So
you're burning these 3 nerves and I'd say 50, 60% of the people don't feel any better. So you just wasted time. You did a procedure that you knew ahead of time it's probably not going to work unless you do all the nerves.
And the patients, their hopes get raised. Like this might be the one that takes it out, and the insurance companies tie your hands. Like you can't do any better.
Well,
not right away. Anyway.
I've had patients say, "Well, doc, can I pay for it?"
Yeah,
now, that's a gray area. I accept Medicare,
right?
Insurance company, Medicare. And if you're participating for Medicare, you can't charge the patient because Medicare, I'm part of Medicare. So that's part of their rules. They'll throw you out. Now, when I say it's a gray area, it's a known fact that if there's a code or something that Medicare says we do not recognize, we do not pay for, at that point, you could charge the patient. Now, we're doing some investigating now, research and seeing if we can charge a patient to do the upper levels. Some of them really need it. Some of them really want to pay for it. It's not going to cost a lot. I mean, it's not like you go to the hospital and you go home after 2 days with a $40,000 bill. That doesn't happen in my office.
Right.
We're very reasonable, especially patients that don't have insurance, especially patients that don't have insurance out of network. we're talking about insurance now, and this is on my mind. We'll get back to some of the other things we do,
Sure.
but let's talk a little bit about insurance.
This is interesting. I like this. Yeah, I want to hear.
I was in network for, I don't know if it's appropriate for me to name some of the insurance companies. Maybe we'll be political and not mention the names.
Yeah, play it
But
safe.
it goes right across the board in any commercial insurance that if you participate in, let's say, Medicare, which is not commercial, it's basically federal, but they got all that other crap, Medicare Disadvantage, I call it.
Yeah.
I call it this way, which is another
Mess.
I'm getting an anxiety attack. But it's just like overwhelming.
Yeah.
And but let's talk about the private insurances where you pay a premium, and you pay every month, and you pay a lot. And it depends on how much you pay is what you get. You get what you pay for.
Right.
And sometimes you don't. Most of the time, you don't get what you pay for when it comes to insurance companies. They got high deductibles. They got big co-pays. People don't even understand what that is. I have trouble understanding what deductibles and co-pays. Well, if I accept an insurance company, they tell me that if I stick a needle in you to do a specific injection, you're going to get this much money and that's it. And over the years, the money would get less and less while inflation and my overhead would get more and more to the point where people go bankrupt. Physicians go bankrupt. Now, I don't know whether, this is another political thing. I don't know whether they're in cahoots with the hospitals, with the big disciplines as far as, that now they have big conglomerates of I don't want to mention any names, but they got, like hospitals grouped together and they hire physicians.
Right.
They get fantastic rates from these insurance companies. Me, I'm a solo practitioner. They say I'm a dying practice. Well, not mine particularly. Sometimes it feels like that, but it's a dying field, the private physician.
Private physician, yeah.
To be in private practice. Virtually, it does exist, but we struggle because the insurance companies screw with us.
I think that's a political term anyway, saying that you're dying, and that's coming from the other side to make everybody else think that that's true, and it's not. Yeah.
We had Dr. Radcliffe here last week. He came out on his own, and he actually called me and asked me, "What do you think? Can we survive as private practitioners?" And I said, "Absolutely. I've been doing it for 25 years."
Sure you have, yeah.
And we've had our ups and downs, but we got people like you.
Pandemics,
Jeremy. Man. We have people like you, support groups. You got it. The old days, we didn't market. We didn't market because it was unethical. But today, you got to market it because you got the big conglomerates marketing and saying that no other doctor's better than our doctors. You got to come to us.
I remember when we started marketing, and I would talk to other doctors, and they would think that they didn't belong on TV. They're not like plumbers or groundkeepers, but you have a service, and people need to know it.
Yeah, I mean, well, I have people coming in every day saying, "Doc, thank God I listened to you on the radio or I saw you on TV.
Right.
I didn't even know that what I have could be treated."
Right.
That's why we do it. Of course, we do it to survive too.
I was waiting in line last night for the Frankie Avalon concert. Right, the guy right in front of us. I don't know if you remember this, but I told you I was in Salad Works with Maggie one day, and this guy is shouting, "Jasper, Jasper!" And I was like, I'm looking over, and he's like, "You're in the commercial. You're in that commercial." And his grandson's there. And he's like, "Look at this guy's famous. He's that with that Dr. Jasper, right?" Would you believe he was right in front of us? And he turns around and says, "Hey, we meet again." And he's like shaking my hand. He's like, "Oh, look." And his wife was there. He's like, "Yeah, this is the famous guy from Dr. Jasper."
So you guys hang out in the same places together.
I know. That's what I said. We keep going to the same parties.
Yeah. But back to the insurance again. People got upset that I came out of network with one particular insurance company because they might not have out of network benefits, or they just, they might have a higher copay. They might have a higher deductible because I'm out of network. And I got to explain to them why I came out of network. You can't survive if you're in network today. Maybe if you're a group of 150, 200 doctors in one group where you can negotiate, and they're like, okay, we'll send all your patients and we'll give you more money than we give Dr. Jasper, which I think should be illegal.
Yeah.
It should be straight across the board so that people could pay their overhead. I was not able to pay my overhead. And I got a big overhead. Why? Because I got the state-of-the-art everything in there. I got the best nurses, the best front desk people, the best billers, the best everything, administrators. And they're getting paid good money. And that's why they're the best. Because you don't pay them good. They go somewhere else where they get paid good. And guess what? They're better.
Yeah.
You get what you pay for. You keep repeating that, right? Well, when I'm in network, what do? You negotiate with the insurance companies.
Yeah.
We've been trying to negotiate with the insurance companies forever. Maybe about 6, 7 years ago, we got a decent rate, but then that's 6 or 7 years, and it's gone down since then. So they decrease the amount that they pay you, and the inflation goes up, and you can't even keep up with the they don't even keep up with the inflation. They don't want to hear it. We got to the point where we started negotiating with them again, and they said, and they wouldn't give me any. I said, give us a fair market value, for each individual procedure, and they said, we already give you fair market. No, it isn't. It's less than it was 6 years ago. How could that be fair?
Right.
And I said, well, you tell us how much you need to survive. Okay, so I give it to them. And they're like, well, you're way off. Way off. I didn't even add extra to make money.
Right.
I just gave you the basic to survive.
Yeah.
You said, give me what you need to survive. And I gave you what we need to survive, and we need to negotiate up from there so we can actually earn a living.
Right.
Now, that's to make my surgery center, my office, pay my overhead to survive. Now we got to work up from there. And they said that was way off base.
Yeah, that's ridiculous.
And then I said, no, it isn't. And that was the last communication. Writing letters, emails, calling them. They don't answer the phone. So I had no choice. I had to come out of network.
Yeah.
And now that I'm out of network, I think we're going to survive because, I think we're definitely going to survive. We're always going to survive no matter what.
Yeah.
But
these decisions are thought out, like, yeah.
And then, but what I like to put out, and I want to, you remember we talking about, I'm going to go on the TV. I want something to talk about. I want to talk about this. You got to be very careful what you say. There are patients out there that don't have insurance. And one thing I want to put out there is that, as everybody knows that knows me, that my main goal is don't do anything unnecessary. No unnecessary surgeries, no unnecessary injections. Nothing that is unnecessary should be done. Now, of course, it takes a little bit of abstract thinking about what is and what is not necessary. And I kind of developed a talent and a unique sense, way of doing it, where I could figure out these things.
Yeah.
and I have a very high success rate in what I do.
Yeah, you do.
And I've replaced a lot of major surgeries with minimally invasive procedures.
Yeah.
Tons of them.
That full open back surgery that people get
Some
offered.
need that. Some people need that.
Yeah.
And you know what? As my patient, I will be the first one to tell you. I don't say spine surgery, absolutely not.
Right.
Traditional spines are absolutely not. I don't say fusions. I get around. I refuse to fuse.
Right.
But when you need fusion, you need fusion.
Yeah.
Don't get me wrong. And I have quite a few surgeons that I know and I'm very close to. And we talk about this, like Dr. Radcliffe and one, and a bunch of other ones that I can name. But we talk about these things, and they understand that there are certain procedures that I could do that they shouldn't be doing,
right?
Unless they want to learn what I do. And a lot of them do learn what I do, and then they do it. But the problem is you don't make that much money doing what I do. So I hate to say it, money tells you what to do.
Yeah.
Sometimes.
Yeah.
Especially if you don't care about your patient as much, but I care about my patients. And so going back to talking about, if there's somebody out there, let's say, and we get these calls every day, listen, I don't have insurance. Can I come in and see Dr. Jasper? Because my friend went to see him and he was going to get surgery, but Dr. Jasper did something where he didn't have to do surgery. And And I heard you talk about the fact you could point them in the right direction.
Mhm.
And when a patient comes in my door with or without insurance, some patients we do for nothing. You know, some single mothers that have they get paid minimum wages. They can't afford insurance, and they call up, you know, and they ask me, Doc, you want to? Now this isn't like a come in free. All single mothers call
Right.
our office, but you know we still do it anyway.
There are special
Yeah,
cases.
tell them come in and we'll take care of them. You know,
Yeah.
because they got to live, they got to work, and we talked about that before on this show.
Yeah.
And I've done a lot of people for nothing. I'm not advertising I do these things for nothing, and everybody can call in. We'll take care of it for nothing.
Yeah, this week you're going to get a lot of calls.
Yeah, but there is a fee.
Yeah,
And depending on you know who you are, what it's about, I don't know. I can't quote fees over the thing because I don't know them.
you don't know them, yeah.
Yeah, but there are fees and they're reasonable, at least to get in for the initial evaluation. Now you need to bring in your MRIs
Mm.
and all the studies that you have,
Yeah,
so that I can give you an honest opinion, and we could come up with something. And even if I treat you, the fees are reasonable. You know, even if they're cash, they're reasonable. And some people come in with like $10,000 deductible. I had a person come in with a $10,000 deductible yesterday.
Yeah.
They're actually a friend of somebody who worked there, brother of somebody who worked there, and we sent him for an MRI, and he probably had to pay all that stuff out of pocket
right.
because he's got a $10,000 deductible. And I saw him. You know, I'm not going to kill a guy. I'm not going to charge him. He's part of the family, right?
All right.
But he needs some procedures now. And he was like, well, whatever it is, I'll pay this. And I said, don't worry about it. You know, go toward your deductible and we'll work something out. You know, it's illegal to not charge, from what I understand. If somebody has a $10,000 deductible, you have to charge these patients. But there are things in place. For example, you get somebody who has minimum insurance and they got high deductibles, but they're poor. You know, but they have the priorities in their mind to actually get insurance for some catastrophic problem that could happen with their family.
Yeah.
Now, can they pay $10,000 deductible? Probably not. In their lifetime, they can't pay that.
Right.
Do they need care? Yes, I give them care. Now, I don't know if I'm supposed to say this online. Do I, send them to collection to ruin their life more? Do I bill them for the rest of their life? Do I threaten them? No. Do I actually? I don't think I'm obligated to get their financial statements either. Right. If somebody truly is like this and they have a hardship, I think there are things in place. We got to talk to the billers, and, lawyers and stuff like that. But there are things in place, from what I understand. Don't quote me on it. There's things in place that I think is a letter of hardship. If there's a letter of hardship, they seriously can't pay for it, I'm not obligated to crucify these people.
Right.
Send them to collections. I do, and it's my practice. It's my choice if I want to send somebody to collections or not. You know, I just don't want that reputation. So the point is here in this conversation about insurance, if you have high deductibles, out-of-network benefits, and you don't have the money, come in and see me. We're not going to say, hand me the money at the door,
Right.
or you can't come in. We're not like that.
A sweaty wad of cash.
We care about the patients. Everybody does. They care about the patients, and we want to save them from getting unnecessary procedures.
Yeah.
And we want them to make them feel good, because they feel good. Guess what? They tell their friends and family, and they come.
Yeah.
And then all of a sudden, everybody feels good.
Word of mouth.
So that's what I put. Don't be afraid to call the office and come in. We'll work something out.
You're a good man, Doc. You really are. You're a good man. You have the feelings and the the everyday BS that people go through. You understand that, and you don't want to create more for them. I mean, how many doctors are out there doing that? You're just remarkable.
I've seen the consequences of bad things being done to patients, where their lives are ruined. I feel so bad for them. Their lives are ruined. They might have another 20 years left in their life, and it's going to be miserable.
Yeah.
And there's ways to avoid that. Sometimes there isn't, but most of the time, the majority of them, there's ways to avoid it, especially with the technology and the evolution and the genesis of the new procedures that are coming out.
Yeah.
Just recently there's new procedures coming out. We can treat spinal stenosis now with without actually putting spacers in on some selective patients.
Mm.
And those a certain selected patient with the spacers, and we can avoid major spine surgery. You can avoid laminectomies, hemilaminectomies. You can avoid fusion, anterior fusion, posterior fusion, lateral fusion. You can avoid all that stuff. It's just not needed anymore in majority of the patients. But like I said, I have patients that need it.
Yeah.
And I won't take that away from the surgeons and the patients. And when they do need it, they need it. Of course, if you do it on strictly the patients that need it, not on the patients that don't need it, there'd be a less number of people getting failed back syndrome, failed back surgery syndrome. Like I always tell patients, if you don't need something and you do it, there's a chance that something bad can happen. Because we sign consents, and we don't even talk about this. You sign a consent as a patient. You sign a consent saying that even if the doctor performs the procedure in a perfectly executed way, within the standard of care, prudent, with no negligence, something bad can happen.
Right.
It happens, So you don't do things that let's do this to prevent it from coming. No, you can't. I've had patients say, Doc, I feel good now, but can I come in like in a month for a booster shot? What do you mean a booster shot? Well, I still feel good, but maybe it'll extend it. I said, this is not COVID vaccine.
Yeah. You're not a Chevrolet where you need a tune-up.
Yeah, we don't need to do an oil change periodically or grease fittings.
Right.
But if the symptoms come, like you're driving down the road, you hear, you need some grease fittings greased. And if you're walking down the road and you're getting pain down your leg, you need a tune-up. You need something taken care of to get rid of that.
I was in, we went to McDonald's before we went to the concert, right? And this woman walks in on a cane. Her daughter's there, and she's all hunched over, like bent over. And I'm like, oh. And once more, she was rushing to get to a seat, and I said, oh, spinal stenosis right there.
Yeah, you usually could tell right away. They're leaning forward. But sometimes it can fool you because, like my father, he has no spinal stenosis. He leans forward. He's on a walker. And he's only on a walker because he leans forward so much. Gravity will just make him fall over.
Yeah.
And it's because he had compression fractures of the spine. And I actually fixed them for him. And when you have compression fractures, sometimes if they're bad enough, they wedge forward and they make you physically, anatomically lean forward all the time at that point.
I don't know if I said this to you before, but before I came to you, I was like that a great deal. I was always looking for the next chair. Anywhere we were going, if I was going out with people, because I hated having to stay home. I hated to have to stay out of things, and everybody else was like living and doing things, and I wanted to go and do these things too. But I was always looking for the next chair, and it's so difficult. And eventually you just give up, going out, and you kind of you get complacent with your pain, and you just stay inside. And I still say to this day, and I say this a lot on this show, we found you on the internet. My wife did, Maggie did, and that's the best thing that ever happened to me.
Thank you.
The best thing that ever happened
that
to
makes
me.
me happy.
Yeah.
That makes me feel good.
Yeah.
You're talking about couch potato. You don't want to leave. You don't want to do anything. And it brings into mind a patient we had, I think not this week past, but the week before. And the guy's a nice guy. He's a quiet guy. His wife is nobody wants to go see him really because she's yelling all the time, yelling at him all the time. He's lazy. He doesn't want to do anything.
Yeah, because if you don't suffer pain, you have no frame of reference to understand what your spouse might be going through.
He used to walk around. He used to do everything, do things for me. He doesn't want to do it anymore. Doc, can you tell him to please get up and force himself? I said, and it's not the first time I told her this. Yeah. And she's berating this poor guy, and he doesn't say anything. Nice guy. And I said to him, well, joking around, I said, how long has she been treating you like this? He goes, well, A whole marriage.
Yeah,
It kind of you kind of like make light of the whole situation.
that's cool though.
But, you know,
That's
what do
cool.
and I tell the lady, say, listen, when you can't walk, you can't stand because it hurts.
Right.
You feel good sitting down. You feel good leaning over, laying down. You didn't want to do anything but that.
Right.
All right. I mean, it's bad enough that they got to go to the bathroom and hurt.
Yeah.
And then,
see, when you find a comfortable position, for me, it was flat on my belly. Right. That was the only position I could get into where the pain receded, you know? And so I stayed in that position for many years.
well, that's how we met. You were
Yeah.
in that position.
Remember, they wheeled me in on
And-
the gurney
and I
like
think-
that.
I think in your initial chart, because I take pictures of all the patients,
Yeah.
you're in there laying on a gurney on your belly, holding up your head with your hands.
Yeah.
On your elbows.
Wait, hey, let me show you, buddy. I did this. Yeah, no, I mean, and you know, so for all of these people out there that are trying to get some reprieve from their pain, because maybe they're stuck in a position where the pain pills have stopped working from other doctors, and stuff, because that's where I was, lying in your safe position is all you want to do.
Yeah.
You know,
So she, I gave up trying to tell her, but what we do is we're slowly making this guy better, because he has multiple levels of spinal stenosis, and we're fixing him one at a time. Hopefully, he's already walking better, and she's obviously complaining less. And you would think that she would understand that, you know, now he's doing it not because she's yelling at him, because it doesn't hurt as much. She's thinking, well, he's finally listening to me.
He's finally getting through to him after all these years.
I said to her, give me some credit. I'm making it easy for him to walk.
Right.
And he just smirks. He smirks.
But I mean, Jesus, you're not just a pain doctor, but you're a marriage counselor at this point.
I tell him, I said, listen, I hate to tell you, but I'm not a marriage counselor. Oh, that reminds me, we had a patient yesterday. She was another patient who was like 4 foot nothing.
Yeah.
And she had long hair, right? And she had to be probably maybe 78, something like that.
Right.
So, I mean, she looked like an old hippie.
Yeah.
Because now the old hippies are like in that age range now.
Right.
An old hippie, and she had like hippie clothes on, and sweet lady, but she was a talker.
Oh, yeah.
And meantime, I have the nurses or X-ray tech or somebody go in there to take the intake, so to make it faster for us to go. They come in and give me a report, and I already know what's going on, everything about the patient. Of course, you get in there, you know, you elaborate on a few things. I want to ask some certain questions, but this lady wanted to tell the whole thing all over again.
Right.
And they warned me that she doesn't want to stop talking, and she'll interrupt you and talk to you about other stuff.
Right.
Well, she started that, and she goes, you know, now the lady's like 80, almost 80 years old, and she's talking about, you know, this all started when I was 30 years old, and when I was 30,
I was like, knee high to a grasshopper when this started.
I said to myself, wait a minute, let me calculate how many years this story's going to be. Right. Meantime, we're backed up like an hour and a half, maybe 2 hours.
Yeah.
And I'm listening to this lady, and I already know the story. I said, you know, I really know the story. And she told me, she goes, but I want to tell you guys. I said, no. I said, please, I know the story. I could tell you the story now.
Right.
And then finally calm her down. And then somewhere along the line, she starts saying, you know where I really think this happened? Was when I was born. I was like, no.
Oh my God.
I said, please. I was afraid to listen to the story when you were 33 years old to today. Now I'm going to start from when you're born. And she starts going into it. And I said, you can't. You got to stop.
Your life story.
I'm sure if you could remember when you were born and you're telling me these stories, it's not going to matter in this interview here. And then in the background, I can hear Michelle, all any other, because she's listening. Yeah. She is laughing her butt off, laughing her ass off. I mean, I have not heard her laugh that hard since it was so far away that the lady didn't even know she was laughing at our conversation.
Right.
But it was comical. And then I got Nicole standing there trying to hold a straight face.
Yeah. I don't know how she could.
She couldn't hold a straight face. She's laughing. The lady's like going on and on about her childhood now.
Oh my God.
But she's a nice lady.
Yeah.
She's entertaining.
Yeah.
But you got to know, it's hard to cut people off sometimes when you have an office full of patients.
I gotta tell you, just from my experience, when you're suffering pain, in conversation, the first stage is always talking about it. Okay.
Yeah.
And then
That's why they have group therapies.
Yeah, well, yeah. I mean, but everybody you see, you talk about it because you explain why you're leaning or laying or something like that. There's something you have to explain to everybody. And then the second stage is that you're sick to death of talking about it.
Yeah.
But anyway, that's why we have doctors like Dr. Gabriele Jasper, MD. And you can make a call. It's up on the screen and book an appointment with Dr. Jasper. Please call 732-262-0700. And, the doc will take care of you.
Well, we talked about arthritis, which is a great procedure. So if anybody told you or you feel you have arthritis in the spine, like I said, usually the pain is more in the morning. You know what else? It's characteristic.
Yeah.
For a lady or a man leaning, like a man shaving in the morning, usually lean forward. That hurts.
That half bend. Yeah.
That hurts. When a lady's putting makeup on, that's why a lot of them, the older ones, sit down and do it. They got their little thing over there. And also, if you happen to be sitting down for like anywhere from like 15 minutes to an hour, and that initial getting up, and you're like, and then you start walking, and it sort of clears up a little bit.
Right.
That's your classical pain from the arthritis of the spine, and that we could treat. It works wonders. You got to treat it at the right time, though. And I'm not going to tell you when and when not to treat it, because then there might be some pain doctors out there that might get my secrets.
Yeah.
Right? Because I get a lot of patients that they've treated them at the wrong time and it didn't work.
You just gave me a great idea for an invention, like an ergonomic bathroom sink for men, so they don't have to bend over. Or
you can just send them to me. I get rid of it.
Yeah.
I put you right out of business.
Put me right out of business. Well, I still got the his and her toilet. They're like, well, it's already invented where you can the toilets are joined and you can sit facing this way, she can sit facing that way, and you can hold hands.
But that ain't right.
That ain't right.
But I do have, when I bought my house, one of the characteristics that I like in my house was in the main the master bedroom.
Mm-hmm.
It was like a little hut built in there. It was like, my house is built. It's kind of eclectic, and it's a weird house. I've never seen it before. The way
your house, you can get lost in your house.
People say my house is enchanting,
right?
on the way it's been designed. But it's now we're talking about my house. Well, the house was built by a guy who built and demolished churches.
Really?
Yeah. So in other words, the supporting structures were all built into this chimney, and like a church or a barn. You don't see any supporting inside walls in a church.
Right.
It's like a barn where it's all supported on the outside. That's how mine is. And then they put floors in it, and in the floors they put little huts. Like the bathroom is one little hut with a roof on it. My bathroom, my bedroom, the master bedroom, it's got like a hut, but it's got two doors. He showed me. He goes, "Here's two doors." And I said, "Why you got two doors?" He goes, "This bathroom's for the lady, and this one's for the man."
Oh wow!
So that the lady doesn't mess up the man bathroom.
Right.
That's what he said. I said, "That's cool." We like that concept.
Right.
But anyway, I don't know where that came up.
Well, we're talking about toilets.
Oh, you were talking. But anyway, so talk about. When you talk about toilet, somebody sitting on a toilet and tries to get up.
Right.
That's another time you get a lot of back pain from arthritis.
Yeah.
And we burn the nerves, and it goes.
You know what they did? They did invent that I noticed recently, because going to the bathroom, essentially, we're not meant to sit upright and go. So they've made these new toilets where it's healthier to, like, it's more of a squatting position you're sitting down in, like maybe old Neanderthals would have done, because that's how the body is supposedly built for, is that kind of thing. But we keep doing it standing up, and we're bearing down, and you know, you can get, you've always told me you can get herniated by doing that, bearing down. So
In a Valsalva maneuver.
yeah. Well, that's enough about toilets.
Well, it hurts. When somebody has a herniated disc, that's one of the characteristics of it.
Yeah.
Sharp pain down the leg, sharp pain in the back. When it happens when you sneeze or cough, or you have a bowel movement,
Right.
that's one of the symptoms of a herniated disc, especially if it never happened before, and it could be an acute herniated disc, which could be very painful.
I tell everybody that. Ever since you told me, I tell everybody that. I'm like,
How
about, you know, you can just by sneezing or tying your shoe.
Yeah, that's a character.
You know?
It's a classical symptom of a herniated disc pinching a nerve.
Mhm.
And of course, the same thing can happen when you have discogenic pain. That's more low back pain. And you can treat that too. So there's so much. There's new stuff coming out for discogenic pain, spinal stenosis. We didn't talk about that, but we talk about it every time. And I like to say it because the people that already know about it, I'm sure they don't mind, because that's how they found out about me talking about it. Somebody who has spinal stenosis is somebody who can't walk far, and they walk, and when they can't walk, they get to a certain point where it hurts their back. It usually goes into the buttocks area, sometimes down the leg, but most of the time lower back into the buttocks, and they get to the point where they got to sit down. As soon as they sit down, it starts to dissipate and goes away.
Yeah.
And most of these people can sit down forever, unless they have a pinched nerve. If they have a pinched nerve at the same time, that's two pain generators. When you sit down, usually the pinched nerve hurts worse. And people can relate to that, like a herniated disc or foraminal stenosis, where the nerve comes out of the spine going down the leg.
Yeah.
People can relate to the fact that it usually happens when they go on a long drive.
Mm.
They got to get in a different position. They put the leg up on the dashboard. These are the people who have a pinched nerve, which you could have a pinched nerve and spinal stenosis at the same time. Like I had a guy yesterday, he had severe spinal stenosis, and I was treating him. He's got to go to physical therapy. He didn't start yet. He couldn't walk far. He couldn't stand up straight. And I said, I bet you feel good sitting down. He goes, no, doc, I don't. I was like, well, and I was already making a plan on treating his central canal stenosis with maybe a spacer, or the new one, Miles procedure, they call it. And but he was like, no, I don't feel better. In fact, I feel worse. It doesn't go along the symptoms of spinal stenosis that I'm going to treat. And I said, well, now right away, I'm like, it doesn't make sense.
Right.
And then finally I said to him, what, your back pain still hurts when you sit down? He goes, yeah. No, that doesn't make sense. I said, I hate to do this procedure on you. And at the end of the day, I do this procedure and you know better.
Right.
Where else is your pain? He goes, which he didn't tell us. Well, it shoots down my left leg. Oh, so that hurts when you're sitting down or standing up? When I sit down. And it clicked in my mind what the problem is. He's got two pain generators. Pinched nerve. He's got spinal stenosis. And when you pinch a nerve, there's a component of a pinched nerve that hurts your back.
Right.
So it usually radiates from the back down the leg. It's a completely different pain generator. It's giving you back pain. This is what I talk about. You have to have a doctor that understands all of this. You've got to have that abstract thinking.
And at the top of the show, you said it's like being a detective, and that's what you have to do. Yeah.
And that's what I am. You know, you look for clues.
Yeah.
You know, you ask questions. Like a detective goes, like Columbo, you know, he's asking, excuse me, do you mind? I have one more question I got to ask you.
I love Columbo.
And that's I figured it out. I said, well, and then see that this guy's a candidate for the spacer. He's not a candidate, as far as I'm concerned, in my experience, for, let's say, to go in there and just take out the ligament. The ligament, you can't just go take the ligament because it's getting pinched out the side. Right. You got to open that. When you open the spacer, it opens up the holes where the nerves come out too. It gets rid of that pain. That's the first step. And if it doesn't, then we go to the next step.
Right.
So that's spinal stenosis together with the treatment of radicular pain, sciatica pain, and spinal stenosis pain. We got a guy that came in with post-traumatic stress, who hopefully is going to benefit from stellate ganglion blocks. There's studies out there that are saying that if you do a stellate ganglion block, which is turning off the sympathetic nervous system with a needle along the stellate ganglion, which is a sympathetic chain right in the anterior part of your spine, right?
Mm.
And you put the needle in under X-ray, strategically put it in the right spot, precision injection. You also test it with a little dye, make sure and you turn it off. And then when it comes back, people have less traumatic stress.
Well, what the traumatic, how is it affecting that? I mean, like PTSD, is that it? Yeah.
It is, but nobody knows.
Nobody knows. All right.
Nobody knows it because it's the same mechanism as if somebody has reflex sympathetic dystrophy. It's also called CRIPS, chronic regional pain syndrome.
Okay.
Sympathetic pain, mediated pain. These are and people are out there listening, and doctors that know about it.
Yeah.
Patients that have it, and patients' family members that have somebody that has it. They know it's a terrible disease. I'm going to refer to it as reflex sympathetic dystrophy, RSD.
Yeah.
That's the old terminology, and most people know about that. Like the name goes, different names for it.
Yeah.
There's different theories on why it happens. But if you catch it early enough and you diagnose it early enough, you do sympathetic chain blocks, and it can get rid of it or make it a lot better. And that's one of the diagnostic tests to see if you have it. Somebody has severe pain down the arm, let's say, burning pain, allodynia where you can't touch it, it hurts, hyperalgia where you create a pain stimuli, but they perceive it as a lot worse than you've created the pain. And you give them a sympathetic chain block, it all goes away immediately after 10, 15 minutes when the local anesthetic takes effect. You turn it off so that pain will go away. If it does, then that's sympathetic mediated pain or RSD. If it doesn't, then there's another source of that pain somewhere else, and you got to find it. But if anybody's been diagnosed with that, or you think you might have it, it's usually an extremity, and it's severe burning. You can't. Cold water bothers it. Hot water bothers it. The sheets sometimes they sleep with their leg or their arm outside the sheets because just sheets rubbing across it.
Yeah,
hurts.
Yeah.
They don't want anybody touching it. They go sleeveless sometimes. Most of the time they go sleeveless. If it's one arm, you'll see somebody with no sleeve on that arm.
Yeah.
These are the people that have that problem. And they've come up with medications today that calm that down too.
Yeah.
So together with certain types of medications designed for that and injections, you can make people feel pretty good. And another thing to treat that, which works wonders, is a spinal cord stimulator.
Right.
They've showed studies where people who have RSD that let's say of the extremity. I had a guy that had a severe RSD of the lower extremities, and I put a spinal cord stimulator, and it turned off the pain completely, to the point where he came back and he told me, I was ready to kill myself until you put this in.
Yeah.
And they also have studies that show that if you keep it in for a certain period of time and you slowly turn it off, that it actually not cures it, but the pain is not that severe, or the pain is gone. It kind of makes it burn itself out.
Right.
And that's rare, but it does happen, and it's worth the risk to do it. And if nothing works when it comes to RSD, that's the probably, as they say, the last resort.
Yeah.
Put a spinal cord stimulator in. You can put it in all the way up into the neck for the upper extremities. You can put it in the lumbar thoracic area for the lower extremities, and it works well. And that's one of the main reasons why you put spinal cord stimulators in. That's a real indication for it. There's a lot of spinal cord stimulators going in that's not indicated, but we're not going to go there today.
Yeah, yeah.
Let's not talk too negative.
Right.
And what else is it that we do that we can tell people that we do?
Well, you take everything from joints, headache, severe
regenerative
headaches.
medicine, stem cells, amniotic tissue, platelet-rich plasma.
Yeah.
Insurance companies haven't caught on yet, but I do it to myself. There's a new amniotic tissue company that came out with a friend of mine's daughter sells it. She's a rep, and I've been using that lately. And it's about the same amount of money as any other injection, except stem cells in itself are very expensive. And you got to watch where you go with this.
Yeah.
People, there are doctors and companies that are taking advantage of people's emotions, like saying that they can cure dementia, they can cure lupus, they can cure muscular dystrophy. I mean, a whole list of ridiculous things that they say they can cure, which they can't. And they charge you $10,000, $15,000, and you get robbed.
Yeah.
And it doesn't work because they've done studies that show that it's a slight improvement, but negligible. You know. But and in fact, I got given injections, all the stuff that I've done over my life. I got arthritis in my thumb, and when I press the needle down, it hurts. And I use this latest form of amniotic tissue, which insurance companies don't pay for. I paid for it myself, and my thumb really feels good for the first time in years.
Yeah.
And I was going to do it yesterday. I just remember now. I forgot.
Right.
But I got my AC joint hurts. And my glomerular joint, my shoulder, 2 joints in my shoulder. I did a patient this week, both of them, and both joints. And I'm going to see how he does. But
that's great.
his might be a little worse than mine. But I'm going to do that next week, and hopefully it turns out like my thumb.
Right.
You know, when I work out, it hurts like hell. Certain positions I can't lay on that side. And that's on its way out, those joints. But hopefully one day. So is Dr. Schneider coming in today?
Yeah, I think she's probably already downstairs. I do want to make an announcement. We coming soon, we will be doing a show possibly on Wednesdays with Dr. Skoblar. Another, he's a doctor at the Jasper Spine Institute. He's got a lot of knowledge that he's going to bring to this show, and it's going to offset when Dr. Jasper is unable to come in. So we'll get more shows out there for you guys on Painless. Look forward to that. Dr. Matthew Skoblar is going to be joining us here on Painless.
What time?
We don't know yet. We it's still in the and it might be due to a schedule that it might fluctuate throughout Wednesday, but I'll be sure to post something to let you guys know when we're going live. And that's important to like us on Facebook, like us on YouTube, because if we do go live, you will get those notifications instantly. So we have, so you can join the show, ask your questions. If you're suffering pain, that's the perfect time to start pumping us out some questions. So either Dr. Jasper or Dr. Skoblar can tell you what they can do with your pain. Okay.
Well, if you guys want to get in touch with us, give us a call at the Jasper Spine Institute, which is 732-262-0700.
Yeah.
We're located at 74 Brick Boulevard, right behind the Roy Rogers. It's right at the intersection of Toms River and Bricktown. So it's very close to most people listening, except people listening abroad.
Right.
And it's right across from Burlington Coat Factory, Bank of America. And by the way, listening abroad, we got a guy coming in from Colombia to get his spinal stenosis taken care of.
Oh,
just the latest in people coming in from abroad.
Yeah, I always watch our show with abroad.
Oh, do you?
Yeah, I do.
All right, everybody. Thank you very much, and hopefully we'll talk to you next Saturday.
That's right.
Please. And hopefully we'll have the telephone.
Yeah, we'll get that ready. We'll get that ready.
People can call in.
For more information about Dr. Gabriele Jasper, please go to jaspermd.com. And remember, guys, please try to share our shows. It's only you can make this show grow bigger. And that's much appreciated by us. So until next time, Doc.
Thank you very much.